So, good afternoon. Today we are going to have a chat about the canine babesiosis. When it comes to canine babesiosis, it's a nightmare for every clinician because no matter how uh, forward we have gone in the treatment modalities, but we still don't have a perfect cure for this disease. So, it is a pyroplasmic disease and very little literature is available on this. Why? Because in most of the European countries, prophylaxis is a major breakthrough. We go for prophylaxis. Tick control is very important, but when it comes to treatment modalities, they are very less available, and that's the reason very little research has been done on it. But we have different treatment modalities where we can control the infection, we can manage the patient. It is more or less sometimes felt for me as a diabetes, where you have to put your patient constantly on the treatment, but yeah, you can manage the symptoms, you cannot properly eliminate the disease. The same thing happens with canine baby issues, although the difference lies within the etiology. When we talk about diabetes, it is a metabolic disease, but canine babesiosis is an infective protozoal disease, pyroplasmic disease. So today we're going to discuss about it, and I am going to point out major treatment modalities. I'm going to concentrate on that only. So it is not a parasitology lecture. It is something related to internal medicine, where because most of the cases in my clinical practice and in your clinical practice as well. So canine babesiosis is going to be the major disease. So it's a tick transmitted disease, haemoprotozoal infection. It happens to cattle, also to buffalo, horse, sheep, goat, dog, pig, wild animals. It can infect anyone. And primarily, the disease is characterized by pyrexia, fever, hemoglobinuria, anemia. Uh, the difference lies within the etiology. In cattle. Uh, the major organism which causes it is Babesia bigemina. But when it comes to dogs or canine species, we usually the major invading species are Babesia gibsoni, Babesia canis, uh, Babesia gibsoni, Babesia canis. That's what I have seen most of the time in my clinical practice. There are several other strong pathogenic, which we are going to discuss in it. The other species which include Babesia gibsoni, Babesia canis, Babesia rossi, Babesia vogeli. So it is divided into two groups, usually large form based on the size, 2.5 to 5 micrometer long, and small size, less than 2.5 micrometer long. So it's a pyriform, it's a pear-shaped organism. It is sometimes oval or sometimes it is a bizarre in structure. So the angle between the two parasite in large form is acute and in small form it's obtuse angle. So usually when we see Babesia gibsoni, which is a very small form Babesial infection, the angle is obtuse. But when we go to the large form, Babesia canis or Babesia vogeli, Babesia rossi, the angle is obtuse, right? So the species involved are in cattle and buffalo, it is Babesia bigemina, Babesia bovis, Babesia divergens, Babesia divergens. And when it comes to horse, Babesia equi, Babesia cabali, Babesia motasi, Babesia ovis. In pig, similarly in dog, Babesia canis, and in cat, Babesia felis. There is another Babesia which I discussed, Babesia rossi, vogeli, and Babesia microti. There is an infection uh, which can infect. It has a zoonotic potential also, so it has infected humans also. So epidemiology. It was placed on record by Babes in 1888 from blood from the African cattle. It is most or less present worldwide. It affects all the cattle. Young cattle are highly susceptible. Buffaloes. Similarly, young cattle, which are young in age, they are more susceptible to the aggravated form of disease. Right now, the mode of transmission. Uh, Usually, the disease is transmitted under natural conditions. It is transmitted from the affected ones to the healthy animals through ticks. So it is a vector-borne disease, and the major uh, vector in it are the ticks, Boophilus microplus, Boophilus annulatus. They are the major species of bovine babesiosis in India. In the horse, Dermatocenta, Hyaloma, Epicephalus, they can cause babesia species. There is another species called Hemiphysalis, usually Babesia uh, canis or Babesia gibsoni. Uh, they can be transmitted by this Rhipicephalus, Hemiphysalis, Dermatocenter, and Exodistics. So, Dermatocenter, Rhipicephalus, Hyaloma, and Hemiphysalis. They're the major ticks in major genera in the ticks which can transmit canine babesiosis, right? So usually the reproduction remains sexual within the ticks, but asexual within the dogs. Okay, so it has biphase, bi-reproductive phase, right? Within the ticks, there is sexual reproduction, which is a separate topic in parasitology. I don't have to delve into that. Yeah, maybe I know less about it also because I am focused more on the clinical perspectives, right? So in general, it is transmitted transovarily and transstadily both, right? So the pathogenesis, it causes intravascular hemolysis. It can cause DIC also, disseminated intravascular coagulopathy. Infected erythrocytes increase the proteolytic enzymes, infected erythrocytes. There is increased erythrocytic fragility, finally hypotensive shock, and disseminated intravascular coagulation, right? Parasitemia, fever, and hemoglobinuria. They are the main clinical treatments. So if a case comes to you with fever and hemoglobinuria, uh, which we usually call in our clinical practice coffee color urine. It's a very terminal, or we can say the aggravated chronic state. In acute form. So the major thing you will see the coffee color urine. So you will notice it's a hemoglobinuria. So usually the death is because of anemia, anemic anemic anoxia we call it, because within our country and within our practice, it is very difficult to go for blood transfusion, which is a major managemental practice in the worldwide, and that is something which is very life-saving. But yeah, within our country, it is very difficult. Although in some clinical practices, some physicians and some multi-specialty hospitals have started blood donations, blood transfusions. So that is a very, no, I think the major thing, apart from any anti-infective therapy, the major managemental therapy for this disease is blood transfusion, right? We're going to discuss it in detail. So these are the major clinical symptoms. High fever. Usually the dog will present with high fever and anorexia. That is very common. Whenever you get some dog in clinical practice, not a puppy but a dog with high fever and anorexia, so you have to rule out any haemoprotozoal infection. Okay, so for this will be followed by severe jaundice, hemoglobinuria, and marked anemia, right? So these are the five forms. Although we cannot no, there is no any kind of a literature, no, as long as we go through Ittinger or some other standard clinical book, these forms are never talked about. Okay, when we see like elementary form, respiratory form, it's basically for a very clear clinical understanding. Once you go advanced to the case and then you start to delve into the diagnosis, so these are kind of checkpoints you will see. Okay, so this is actually basically these are the symptoms which we see. So but they can be non-specific. You mean to say, if I'm talking about elementary form, it does not mean stomatitis, because stomatitis can be because of uremia also. So there is no gold standard, like, yeah, these five forms you will see: elementary form, respiratory form, circulatory form, ocular form. Basically they are, there is nothing as such. Okay, so it's basically it infects the patient, and once it infects the patient, we go through non-specific signs. Okay, so for better understanding, we just divide it into forms. So in elementary form, you can see stomatitis also, but it is not 100% that the stomatitis you're getting is because of babesia, right? But yeah, in babesia, you will see stomatitis, you can see gastritis, you can see enteritis. Yeah, respiratory form is quite pronounced. I have seen cases with marked pleural effusion at the later stage because of anemic anoxia. So it is characterized by respiratory distress. There is circulatory form, which is characterized by edema. Ocular form, keratitis, iritis. Here also, in ocular form, it does not mean any case having keratitis or iritis, you will go for VCA diagnosis, right? So these are not diagnostic tools for you. You're going to check like elementary form, tick, respiratory form, tick. No, not like that. Okay. So you have to go through the basics only. For your better understanding, I am putting these forms like so that things become much clear. Okay, and muscular form is characterized by muscle weakness. Okay, then there are atypical signs like dyspnea, cough, convulsions, tonsils, and bleeding from the nostril. Okay, so basically there are two major clinical forms, what we call as complicated and uncomplicated form. So this thing is based more or less on our understanding of disease, right? Because since the disease presents in more chronic stage to us, because the patients regularly come to us back with this second onset. I'm telling you early on that there is no total cure of the disease. Okay, so the dogs stay as a carrier. So once the immune system gets a bit low or high, or the body is under some stress, so it can just start the patient can start having symptoms. So there is not a single management of therapy which is going to eliminate entirely the infection. That's why for a better clinical understanding, we get two forms, basically complicated and uncomplicated form. So in complicated form, there is, because of the hemolytic processes, you can notice acute renal failure. Basically, in the initial stages, it causes acute kidney injury and hepatopathy. So the major systems it involves, the major systems it compromises. Uh, More or less, it is because of the circulatory disturbances. Once there is marked hemolytic anemia, then everything subsequently follows, like the uh, hemoglobinuria, which is very toxic, or which is very which can markedly go to acute kidney injury, right? Then it can also lead to pre-renal azotemia, renal azotemia, direct hepatopathy because of bilirubinemia. So this is all like it becomes a systemic disease then, right? Apart from the infective etiology, you go for the system, because then it becomes easy for you to go for management therapy, because once you get to know the systems it uh, impacts, the systems it compromises, so it becomes easy for us to understand, right? So the complications of complicated things include acute renal failure. In fact, you can have a cerebral signs also, which we call as cerebral babesiosis, right? We can it uncommonly occurs. It has a very poor prognosis. It is caused by basically the endothelial damage, right? So the endothelial damage with microvascular necrosis followed by perivascular edema and hemorrhage. So it has very hyperacute onset, and the pathology is, it's characterized by sludging of these erythrocytes in the small vessels of the brain. So I haven't seen such kind of a disease in my practice, but yeah, it is. Sometimes I used to think like maybe a direct endothelial damage because of the parasites can cause it. But whenever we go through the literature, we go through the research papers, we come to know that no, the The parasites have the affinity to go deep inside the uh, like vessels of the brain. Okay, and the rate of progression is very rapid. The dog can go tetraplegic within hours. Yes, your patient can go tetraplegic within hours. Like it will present with hind limb ataxia, then it can go tetraplegic. Okay? Most dogs will show neurological signs, for example, seizures, and which are more or less sometimes confused as uh, a canine distemper. There can be nystagmus, paddling, vocalization. So these acute and delayed onset symptoms are present. Second, we talked about renal failure. Okay, I'm going to this. So, in case of acute kidney injury, which is common complication, although in complicated form it's very common, but in uncomplicated forms it's very uncommon, which it presents with anuria or oliguria, and that does not improve with the adequate or aggressive fluid therapy. Sometimes you see, dog is not urinating, the patient comes to you and tells you, the dog, sir, the dog is not urinating, and you will go with aggressive fluid therapy thinking that dehydration may be the cause, but you won't. But it won't be corrected. Why? Because there is kidney injury, right? There is hypoperfusion. So at necropsy, at the post-mortem things, the kidneys will be swollen. They will be dark in color and red-brown color urine in the bladder. So microscopically, the renal tubular epithelium are swollen. So actually, this hemoglobinuria, it's directly causing injury to the renal tubules, right? The nephrons. So they cause these morphological lesions have been attributed to anemic hypoxia, which this anemic hypoxia is a resultant of what? It's a resultant of what? It's a resultant of erythrocyte destruction, right? So so renal changes are very common, attributed to hemoglobinuria. Uh, Sometimes we call it as hemoglobinuric nephropathy. So basically, the hemoglobin, which is directly which causes acute kidney injury. So it is a kind of injurious to the kidneys, right? So it is followed by uh, reduced glomerular filtration rate. Okay. So proteinuria, variable enzymeria, azotemia, they have been demonstrated. Second is cerebral signs, which I talked. Then coagulopathy, disseminated intravascular coagulopathy. It is because of the direct endothelial damage, right? Direct endothelial damage. And this DIC is a very broad term, but basically what happens within the system is that uh, you get clot somewhere and bleeding somewhere, right? Because clotting factors become like sometimes there is an endothelial damage, there are excess formation of clots, and somewhere you will see the clots are absent. So in a very layman's term, if we understand it, that the thing is basically we fall short of the clotting factors, right? Because at certain points extra clots are made, and at certain points we get internal bleeding. Why? Because we don't have clotting factors. Icterus is very common because of direct hemolytic anemia and also because of hepatopathy. So the icterus can be intrahepatic and prehepatic also, right? It is both. Hepatopathy, immune mediated hemolytic anemia, very common, and it is very at times managed with corticosteroids. And takeaway notice for that corticosteroid, usually prednisone, is used. Uh, it takes disease to the chronic form. So yeah, we don't have any other options at that moment. We go with high dose of corticosteroids, immune suppressive dose of corticosteroids, immune mediated hemolytic anemia. Then acute respiratory, I told you I have seen pleural effusion because of babesia, right? Hemoconcentration, hypotension, cardiac involvement, and pancreatitis. Yes, of course. Uh, Normal amylase and lipase levels are increased. Now, in uncomplicated form, you can see acute hemolysis. There is fever, there is anorexia, there is depression, pale mucous membrane, splenomegaly. It's very common. So it's an ultrasound guided procedure. You go with ultrasonography, you will see splenomegaly. And if there is babesia, splenomegaly is present. And water hammer pulse. It's a very typical auscultating finding. So this form may exist mild, moderate, and severe, which depends on the severity. Although in horses it's a different thing, but I am not going to discuss about horses right. Okay. Now, what are the takeaway notes from routine blood examinations? You will notice severe anemia in acute forms, right? Severe anemia. You will see leukocyte count will be increased. There will be moderate neutrophilia. There is presence of albumin and bile pigment in the urine. So you can go with the normal routine urine examinations. Okay. So, and when we go to liver functioning tests, you will see ALT, AST, IGPT. They all are increased. I'm telling you the two major complications of babesia is babesia induced acute kidney injury and babesia induced acute liver injury. So both hepatopathy and nephropathy are present. And I explained uh, why there is nephropathy, right? Hepatopathy is basically the hepatopathies occur with other complications with pancreatitis. Okay, so but acute kidney injury it is more or less in uh, directly linked to the hemoglobin. Okay, that causes the injury. Then the basic gold standard is thin smear, blood thin smear. You go for ELISA, PCR. For if nothing comes out with the blood smear, you go for PCR. Okay, right. So this is here in this image. You can clearly see this is the babesia species. Okay, so the highly pathogenic form has been seen as babesia vogeli. Okay, so it is mentioned here that yeah, we can successfully treat them, but more or less it is very different, very difficult in clinical practice. So the relapse is more, the remission is very less. But earlier it was mentioned in the earlier literature that yeah, diaminoxine acetate given at the dose rate of 3.5 milligram per kg body weight subcutaneously or intramuscularly, it successfully eliminates, but it does not eliminate the carrier still. That's very important. Or sometimes we go with imidocarb, uh, imidocarb 6.6 milligram per kg for 14 days apart. Supply. Or you can go with 7.5 milligram per kg body weight, only a single shot, right? So now I go to the treatment modalities of babesia. More or less, uh, before the treatment, when we come to the diagnostic imaging thing, I want to discuss it in a yet bit detail. So the case is presented to you, so you don't have to be directly aimed to eliminate the infection. So the management of therapy is important. I'm telling you, I have seen patients dying because of anemia. Why? Because we don't have any blood transfusions here. And then some patients I have seen dying because of complications. Why? Because they are overhydrated. The patient is not eating, you give isotonic fluids. It's very wrong. I'm telling you, it's very wrong. Like isotonic fluids overload and then it causes pleural effusion. Why? Go and manage the pleural effusion there. So the things become very complicated. So the thing is, every time when we come at the diagnosis of babesia, the primary thing is you should not be focused to go for PCR, to go for serological tests. You should assess the entire body function. That's why I'm telling you, it's not a disease for me; it's a syndrome for me. For me, the thing is, you have to go for check the major systems. Go for USG. Check if there is any hepatomegaly. Check if there is any splenomegaly. Check if there is any acute kidney injury. Right. So go for myocarditis, go for heart, go for X-rays. Why? So you have to be holistic in approach. When it comes to the treatment, you have to be very holistic in approach. It is not like you will try triple therapy or something, anything else. Or yeah, we have never anti-infective therapies. They work, but that does not mean you're compromising the entire system because of that, right? You are giving anrofloxacin to dogs. Yeah, it is a in one triple modality we use it, but you don't see that it what kind of a damage it is going to cause to the retina. And if the case is presented to you, the management is you have to do the major biochemical tests, including the tests for kidney, tests for liver, tests for for radiographic imaging. including diagnostic imaging, right? That is very important. So in recent things like cytokines were seen, like in, like they have a role, but yeah, although they are not important. Coagulation profiles, I talk about them. Coagulation profiles, very important. Like uh, thrombin, antithrombin complexes, you have to see them. Why? Because you have to manage DIC, right? Similarly, to prevent any kind of a metabolic syndrome, you have to go for acid-base values, go for sodium and potassium, check the anion gap, right? So it is not about treating babesia. It is basically managing this, uh, managing the entire what we call as a, a syndrome, managing the entire metabolic syndrome, which metabolic, respiratory, cardiac. So the takeaway from this lesson is that once a case comes to you, you should remember 3 to 4 things. If it comes with fever, it comes with severe anemia, go for the check for you. If you are lucky enough to go through thin smear examination, you got the invading species. Then you start with checking other profiles as well. Go for the liver functioning test, check if there is any kind of hepatopathy. Go for acute kidney injury, check creatinine and one levels, right? Then third important thing is go for diagnostic imaging. So you can jot them down. Okay, go for diagnostic imaging. Once you go for diagnostic imaging, then check for splenomegaly, check for hepatopathy, check for any kind of changes within the kidney, right? Then uh, go for X-rays, see if there are any kind of respiratory signs, and keeping a check on the hemoglobin concentration. And more important thing, apart from all of this, is that you have to successfully manage the case with acute, with normal hydration. Overhydration is not a key. The dog is not eating, does not matter. If you are giving fluids in very high quantities, it is going to collapse the case. Why? Because overhydration causes fluid deficiency. Already there is the hematocrit values are high. Already the blood is low, hemoglobin levels are low, PCV is low. So you shouldn't, in no case, if you don't have blood transfusions available, the primary thing is you should go with blood transfusions. That is the gold standard. But if you don't have, if you have a complicated case with no blood transfusion, you should never ever go with isotonic fluids. You should never ever go with plasma minders. Sometimes people go with plasma therapy. They directly give, what I should say, these the fluids which expand the blood volume. Expanding blood volume is going to not going to treat the case. It is going to aggravate the symptoms. Why? Because it is going to dilute the blood, right? So the treatment, although there is no treatment which can totally extensively treat the case. But in case of Babesia gypsum in dogs, atacone given at the dose rate of 13.5 or 13.3 milligram per kg body weight, it is given 8 hourly, thrice a day. That means 3 doses. Similarly, with 10 milligram per kg body weight, azithromycin, right? It is given 24 hours. So this is for BBC gypsona. This treatment should be continued for 10 days, and you have to notice for other signs. These are some triple therapies, although they haven't worked very well. But yeah, if you have aggravated cases, you can go with this doxy, clinda, and metro. Doxy, enro, and metro. So this even a drug called amphotericin B, it is an antifungal drug. It has shown some in vitro activity, but yeah, it is still not used in clinical practice, right? It is still not used in clinical practice. So the major thing is you have to manage the case. Uh, you can use atavacone with at a dose rate of 13.3 milligram per kg for BBC Gypsona, right? Similarly, triple therapies include doxy, 5 milligram per kg body weight orally. Similarly, metro, for 15 milligram per kg body weight orally twice, and doxy and clindamycin, 25 milligram per kg body weight. Okay. So in earlier things, we used only monotherapy. Sometimes we only go with doxy. Sometimes we go with clinda only. But that is not in the current cases. In the current scenario, I think Avoiding triple therapies is a major blunder every clinician makes. Like you start you start the treatment with only one thing. Like you start with doxy, then you think if it not works, then you add Clinda, then you add Metro. No, that's not the case. Okay, so you have to go with the triple therapies as well. Okay, so and you can also follow it with subcut doses of diaminosin. Okay, you can give it. So that does not mean subcut dose of diaminosin or subcut doses of aminocarb. So although it has gone resistant to imidacloprid, but yeah, it still works. Like, and one thing is very important: diaminosin diesterate. It can cause central nervous system toxicity in dogs. So keep a check on it. It appears to be very toxic, very toxic to the liver also. So it can cause nervous toxicity. It can cause also liver necrosis. Why? Because it, and when you give repeated dose of it, it is very longer elimination half-life, diaminosin diesterate, right? It has very longer elimination half-life, so it can be toxic. So the takeaway from this lesson, from this lecture, is that once a case is you have a signalment, you have a history of the case, which is coming for babesia. The primary thing is not managing the entire case. The primary thing is you have to go with all other biochemical abnormalities and then manage it well, right? Uh, and even if your PCR comes positive, it's something which I have seen in my practice, right? If PCR comes as positive, but you don't have any other major clinical abnormality, your CBC is normal, your blood parasite is normal, like under the smear you didn't get anything, your liver function tests are normal, your kidney tests are normal, your ultrasounds is normal, you shouldn't go for treatment as well, because yeah, that's a career state, even if it is in RT-PCR also, right? So that's very important, when and why to start treatment and how to start the treatment. So it's not about treating the disease with anti-infective therapies, it's managing the case. In the long run, the drugs like doxy, it's very nephrotoxic at the end. Clindamycin, they are not normal drugs, right? So you should be well aware as when and why to use the therapies. And more or less, atovaquone and azithromycin, it's a promising drug. It has more or less stopped the burden on the owners. It's very cost effective. And the thing is, use very less drugs with more elimination half lives, right? So I think that's all for today. And the takeaway thing is the BBCI is not a disease, it's a syndrome. So syndromic treatment is important. So the primary thing is if a case is presented to you, to not only manage the symptoms, but you also manage other uh, systemic abnormalities, metabolic acidosis, liver injuries, hepatopathies, nephropathies, any kind of cardiac problems because of that. So, and the primary thing is it's a very good initiative by several clinicians, that inducing, starting a blood bank, that is very necessary, because in this, and more or less these drugs, the drugs which are tested with babesia, once they come positive for babesia, they should never be used for transfusions. Okay, so these drugs should never be used, and prophylaxis is very important. Tick control is very important, so we have good therapies for that. So even if you are taking dogs to that prone area, you can start with a single dose of 7.5 milligram per kg body weight imidocarb, and there are other uh, locally acting fipronils or something, like these therapies. So prophylaxis is very important. So the takeaway thing from here is that the while treating a babesia case, if the dog is diagnosed with babesia with thin smear examination or with PCR and it's present with the signs, treat accordingly. Proceed proceed with the usual treatment, usual anti-infective treatment, while managing other signs as well, because more or less the dog does not die because of babesia, it dies because of the complications. So you have to manage the complications very well. The three important complications are nephropathy, hepatopathy, and with the cardiac or respiratory things as well. So thank you. I think that's enough for today.